So I'd like to say hello to everybody today, and I do thank everybody for what has indeed been a beautifully warm and wonderful welcome to joining the Henry Ford family. You guys have always been on the forefront of not only defining and understanding barriers to appropriate optimal health care and addressing disparities in health outcomes, but also in conquering many of the problems that lead to these disparities. And so it's truly an honor to be a part of the Henry Ford Health System and to be able to join you in this battle. So I am going to focus my comments during this presentation on my work in addressing disparities related to breast cancer outcome, and I will mainly be focusing on disparities that are related to this issue of African ancestry being a driver of women having high risk or triple negative breast cancer. I have no disclosures to share with you. Now, whenever we embark on a conversation regarding health outcome disparities, we inevitably end up talking about disparities in socioeconomic status. This is certainly quite appropriate because, as these bar graphs demonstrate, the most commonly utilized metrics for socioeconomic disadvantage, living below the poverty level or lacking health care insurance, both of these features are roughly 2 to 3 times more prevalent in our racial ethnic minorities, such as African Americans and Hispanic Latino Americans, compared to the majority white American population. And it's very easy to imagine that these types of socioeconomic disadvantages turn into barriers to accessing the healthcare system and barriers to receiving appropriate management of major problems such as breast cancer. This ultimately will lead to more advanced stage distribution for breast cancer in African American women because of these socioeconomic disparities, and most tragically, higher mortality rates from breast cancer. However, when we look at the discrete problem of breast cancer in the African American community, there are reasons to suspect that there is more at play in terms of driving these higher mortality rates. And some of these clues can become apparent when we look at these data from a meta-analysis that I and some of my colleagues from the Harvard School of Public Health published in the JCO now 10 years ago, where we very simply combined all of the data that had appeared in the medical literature, published medical literature, looking at survival from breast cancer stratified by African American versus white American ethnic identity, and in studies that specifically adjusted for some measure of socioeconomic status. So this meta-analysis gave us a very robust patient population to analyze more than 13,000 African American breast cancer patients whose survival was compared to more than 75,000 white American breast cancer patients. And again, this was a pooled analysis adjusting for socioeconomic status. And in this pooled analysis, we see that African American breast cancer patients have a statistically significant, almost 30% higher mortality hazard. So again, something associated with African American identity seems to be driving this higher mortality risk above and beyond socioeconomic disadvantage. And indeed, if you look at the other characteristics that describe the breast cancer burden of the African American community, you see several features that we really can't easily tie to socioeconomic disadvantage. For example, historically, until very recently, African American women have had lower lifetime population-based incidence rates of breast cancer compared to white American women. We have a younger age distribution, and so for women younger than the age of 45 years, population-based incidence rates of breast cancer are higher for African American women compared to white American women. And we have a higher frequency of adverse primary tumor features, such as high-grade lesions histologically, the hormone receptor negative and the triple negative cancers. And there is also the very poorly understood higher population-based incidence rates of male breast cancer in the African American community. So it is definitely incumbent upon us to look at all of these other types of factors related to tumor biology and the genetics of breast cancer that might also be playing a role in leading to these higher mortality rates that we see for breast cancer in African Americans. Now, if you look at two of the most basic of statistics related to the breast cancer burden in the United States, we see additional clues that there are features related to the biology of breast cancer in African Americans that is driving some of the mortality difference. So the top two curves here are showing you population-based incidence rates for breast cancer in white American women compared to African American women based upon the surveillance epidemiology and end results program data. And as I alluded to previously, those incidence rates are typically lower for African Americans compared to white Americans over the past several decades. The patterns are different when we look at mortality rates shown by the two curves at the bottom. And until the early 1980s, the population-based mortality rates from breast cancer were actually identical for African Americans and white Americans. And it's not until the mid-1980s that you start to see a separation of these curves, with the separation in these curves being largely due to the fact that breast cancer mortality rates are declining in white Americans, but they are for the most part staying the same in African Americans. So this is, of course, probably due to the fact that tamoxifen became available as adjuvant endocrine therapy for breast cancer in the late 1970s. So by the early 1980s, we start to see the impact of tamoxifen as endocrine therapy on breast cancer mortality rates, with tamoxifen exerting a favorable effect on declining mortality rates. However, the bulk of this advantage in terms of advances in systemic therapy for management of hormone receptor positive breast cancer is only being realized in the white American community because of the fact that African Americans have a substantially higher frequency of having estrogen receptor negative breast cancers. And so with African American women, as shown by these bar graphs, having these higher frequency of ER negative tumors, we are simply not benefiting from the advances made in systemic therapy in the form of improved endocrine treatments. Lisa Carey and colleagues at the Carolina Cancer Study Group have gone one step further in terms of looking at the higher frequencies of ER-positive breast cancers versus ER-negative cancers in white Americans versus African Americans by looking at the frequency of triple-negative breast cancers and at looking at immunohistochemical surrogates for defining the basal subtype of breast cancer, looking not only at ER-PR and HER2/neu markers, but looking at some of the basal cytokeratins. And in this study from the Carolina Breast Cancer Group, they found that African American women, especially in the premenopausal age ranges, had substantially higher frequencies of these triple-negative and basal subtypes of tumors. So several other investigators have now gone on to replicate the findings of Lisa Carey and colleagues from North Carolina. And these patterns remain consistent, whether you're talking about single institution studies or studies conducted on a population basis. The frequency of the triple-negative breast cancers is almost always twofold higher for the African Americans compared to the frequency of triple-negative tumors in the white American patients. The study shown at the very bottom row is provocative for a different reason. The data from the study at the bottom row comes from the population-based California Cancer Registry, but they are looking at male breast cancer as opposed to breast cancer in women. And here you again see that the frequency of triple-negative breast cancers is actually 3 times higher for African American men with breast cancer compared to the frequency of triple-negative breast cancer in white American men. These issues of frequency of triple-negative breast cancer definitely have an impact on what we should be thinking about in terms of the conversation related to screening mammography. The triple-negative breast cancers are very clearly biologically more challenging breast cancers to deal with, and so early detection of triple-negative breast cancer is that much more important. Now, if we start adhering to the United States Preventive Services Task Force recommendation that all women in the United States delay initiation of screening mammography until they reach age 50, you are creating a perfect storm when it comes to the breast cancer mortality risk of African American women. Because African American women are not only more likely to be diagnosed with breast cancer at younger ages, but we are that much more likely to be diagnosed with these biologically challenging triple-negative breast cancers at all ages, but especially in the younger age categories. And so we tried to define this risk and this possible implication of the U.S. Preventive Service Task Force screening mammography recommendation when it comes to breast cancer disparities by, again, looking at the California Cancer Registry, which is a very nicely, accurately maintained population-based registry. So in this study, we were looking specifically at the population-based incidence rates, not frequencies of breast cancer, the population-based incidence rates, the actual counts per 100,000 population of triple-negative tumors in African American compared to white American women in these different age categories. And what we see here is that African American women in their 40s have about twice as high a risk of the triple-negative breast cancers compared to white American women in their 40s. And those rates of triple-negative breast cancers for African American women in their 40s is even higher than the rates of triple-negative breast cancers that you see for white American women in their 50s. And so delaying mammographic screening for African American women in particular very likely will worsen the existing disparities that we see in breast cancer mortality rate between these two population subsets. So the findings that we had from the California cancer study have now been replicated on a larger scale and were noted very prominently in the annual report to the nation on the status of cancer published in the Journal of the National Cancer Institute last spring. And in this study, what the investigators looked at was for the entire nation, based upon SEER data, the population-based incidence rates of triple-negative breast cancer for white Americans, African Americans, and other racial ethnic subsets of the population compared to the incidence rates of the non-triple-negative breast cancers. But what we see is that for all of the different age categories, these population-based incidence rates of triple-negative breast cancer are notably higher for the African Americans compared to the white Americans and the other subsets of the population that were evaluated. So we are seeing an interesting change in the breast cancer burden of African American women most recently with increasing population-based incidence rates of breast cancer. So the American Cancer Society made a special note of this in their publication from this past fall, where they showed that the incidence rates of breast cancer have increased for African American women to the point where they have now reached the incidence rates of breast cancer in white American women. But since the bulk of our improvements in systemic therapy for breast cancer have been in the form of targeted agents that treat the estrogen receptor, the progesterone receptor, and the HER2/neu marker, these rises in breast cancer incidence rates for African American women are being translated into a widening of the mortality gap between African American and white American women. So we have more African American women getting breast cancer, but treatments that are less effective for the types of cancers that are more prevalent in this African American breast cancer community. And so the mortality gap is very definitely increasing. So I have been very excited about being able to work with the Henry Ford Health System in looking at precursors for breast cancer and trying to gain a better understanding of why the breast cancer burden in terms of these breast cancer subtypes and phenotypes seem to differ for one population subset versus the other. And as everybody in the room is probably already aware, one model of breast cancer pathogenesis states that the highly aggressive breast cancers, the triple-negative breast cancers, the basal subtypes, that these types of breast cancers go through a very different pathway in terms of their precursors compared to the breast cancers that tend to be more easily controlled, the hormone receptor positive breast cancers, the non-triple negative breast cancers. And it is the less aggressive cancers, the hormonally responsive breast cancers, that tend to be seen more commonly in patients that have fibrocystic precursors for breast cancers, such as the atypical hyperplasias, the lobular carcinomas in situ. The triple-negative breast cancers, however, seem to be coming from a different pathway and are less commonly associated with those types of precursors. So in looking at the Henry Ford Health System benign breast disease cohort, which is a fabulous cohort of several thousand patients with pathologically proven benign fibrocystic changes, 2,500 African American and more than 3,500 white American women with breast biopsies showing these changes, we've had some interesting findings. One of the interesting findings that has been very gratifying to see is that these women receive fabulous care regardless of racial ethnic identity in the Henry Ford Health System. The method of benign breast disease diagnosis, the management of these benign breast diseases have all been comparable for the African Americans compared to white Americans. So that again shows that the Henry Ford Health System really deserves a lot of credit for the fact that everyone here has, in many situations, not only addressed but conquered healthcare disparities, at least when it comes to management of a problem such as this benign breast disease. So we also wanted to look at, and I'm glad to see that Dr. Chedley is here. Dan was key in developing this benign breast disease cohort, which I'm sure is going to lead to many fascinating findings with regard to the breast cancer burden of African American women. We have gone on to look at the breast cancers that were diagnosed in these women who started out with benign patterns of breast disease. Now, the way that the subsequent breast cancers were diagnosed in these patients was comparable for the African Americans compared to the white Americans, again showing that the Henry Ford Health System is marvelous at giving equal care to patients despite racial ethnic background and identity. However, the most striking finding from this follow-up of this cohort is that even though all of these women started out with similar benign precursors for breast cancer, we still see that the African American women have a more than threefold higher frequency of developing triple-negative breast cancers compared to the white American women. So again, something related to African American identity seems to be driving a risk for developing certain breast cancer phenotypes, and in particular, it's driving a risk for the biologically more aggressive breast cancer phenotypes. Now, many of the features that we have talked about as being classic or characteristic of the breast cancer burden of African American women are the same features that are characteristic of women who have known hereditary susceptibility for breast cancer by virtue of harboring a BRCA1 mutation. Those features being the younger age distribution for breast cancer at diagnosis, the higher frequency of the ER-negative and triple-negative tumors, and the higher frequency of male breast cancer. So this then begs the question of whether or not African ancestry in and of itself is related to some heritable marker for developing certain patterns of disease. And not only is this a powerful opportunity for us to learn more about what is causing disparities in breast cancer domestically here in the United States, but it's a very unique research opportunity for us to learn more about what drives the pathogenesis of these triple-negative cancers, because we really don't have a good handle at this point in time in terms of what causes triple-negative disease. So I and several of my colleagues for the last more than 10 years have been working with some wonderful, wonderful oncology colleagues in Africa to try to define the breast cancer burden of women who have shared ancestry with African American women to get a better handle on the genetics of breast cancer and how these genetics related to African ancestry are associated with risk for certain breast cancer phenotypes. The facility that we've been working with most substantially is a hospital called the Comfort Teaching Hospital located in Kumasi, Ghana. Very importantly, I kind of glossed over it on the previous slide, but Ghana is located in sub-Saharan Western Africa, where a lot of the slave colonies were located, and so we indeed have reason to suspect that there would be a lot of shared ancestry between Ghanaian women in that hospital and contemporary African American women. In one of the very first publications where we looked at our findings, we were comparing the breast cancer burden of the Ghanaian women to the breast cancer burden of African American and white American women. And here again, I am grateful to Dan for his help in providing this comparison patient population. We found what we were actually expecting to find. The very youngest average age of breast cancer diagnosis was seen in Ghana, where the average age is only 48. Now, this is, of course, going to be associated with the fact that the average life expectancy is tragically 2 to 3 decades younger in under-resourced countries compared to more affluent countries such as the United States, because of a whole variety of issues related to disadvantages in healthcare. But we did also see a relatively younger age distribution for the African American women based upon the Henry Ford Health System population, and the eldest average age at breast cancer diagnosis in the Henry Ford Health System white American patients. But we also found that the frequency of triple-negative breast cancer was especially high in the Ghanaian women, with more than 3/4 of the patients in this first study of ours, these Ghanaian women having triple-negative breast cancers. Triple negatives being at intermediate frequency in the African American women, just over 1/4, and at a frequency of about 16% in the white American women from the Henry Ford Health System, which is pretty typical in terms of what we see for frequency of triple-negative breast cancer in women around the United States, if they are white American, and in women of European descent. In a more recent update of this study, we've looked at much larger numbers of Ghanaian breast cancer patients, and most recently looking at more than 230 Ghanaian breast cancer patients. Again, finding what we saw previously, a very young average age at breast cancer diagnosis for the Ghanaian women, but still more than half of the women, and even in this larger patient population, having triple-negative disease. We've worked with yet another hospital in Ghana, the Korle-Bu Teaching Hospital located in Accra, and looking at more than 200 breast cancer patients. Again, the same exact finding, more than half of the women from Accra in Ghana having triple-negative breast cancer. These very high frequencies, with the majority of breast cancers being triple negative in certain parts of Africa, are very different from what you see in any other part of the world. As shown in this list summarizing the frequencies of triple negative breast cancer in different countries, you see typically fewer than 20% of the breast cancers being triple negative in any other part of the world. Now, our epidemiology colleagues have gone on to try to figure out how reproductive factors might impact on the risk of triple-negative breast cancers. And they have demonstrated for us that many of our reproductive risk factors for breast cancer behave very differently when we are talking about how they affect risk of triple-negative breast cancer compared to risk of non-triple-negative breast cancer. And this table is just one example where we are looking at the impact of multiple pregnancies on subsequent breast cancer risk. Historically, we have always said that multiple pregnancies were protective against developing breast cancer, probably because of the impact of multiple pregnancies leading to the breast tissue being associated with fewer hormonal estrogen cycles driven by those 9 months of being pregnant. Now, what we see in these epidemiology studies is that multiple pregnancies really only reduces the risk of getting a non-triple negative breast cancer. But in several studies, it actually suggests that multiple pregnancies increases the likelihood of having a triple negative breast cancer, which then begs the question of whether or not childbearing patterns and the multiple pregnancies might be causing the higher frequency of triple-negative tumors that we see in African American women and in Africa, because we do know that in the United States, African American women are more likely compared to white American women to start childbearing at younger ages and are more likely to have multiple pregnancies. Similarly, in low and middle income countries, the women are more likely to start childbearing at younger ages and to have more pregnancies. However, these childbearing patterns are not consistent in terms of their association with triple-negative breast cancer when you look at the variety of diverse populations in low and middle income countries. So on this table, I'm simply showing you the frequency of triple-negative breast cancers that have been published looking at a whole host of different low and middle income countries. You see in sub-Saharan Africa, most of these studies showing what I showed you before in terms of the triple-negative breast cancer frequency in Ghana, where the frequency of triple-negative tumors is quite high. In other low and middle income countries, such as those in Northern Africa, Southeast Asia, South Asia, you still see relatively lower frequencies of triple-negative breast cancer. So it doesn't seem to be that childbearing patterns in and of themselves are accounting consistently for this high frequency of triple-negative disease. So I and many of my colleagues looking at African ancestry and risk of certain phenotypes are, of course, coming to the conclusion that it is somehow the fact that extent of African ancestry is driving the risk for certain patterns of breast cancer. And so this table, this slide is simply summarizing all of the patterns that we see in terms of average age of breast cancer diagnosis. We see the very youngest average age in women from Western Sub-Saharan Africa, the eldest average age of breast cancer diagnosis for white American and European women, intermediate average age of diagnosis for African Americans. Frequency of male breast cancer is highest in Sub-Saharan Africa, intermediate in African Americans, lowest for white Americans and Europeans. Same issue with these stepwise patterns when we look at proportion of triple-negative tumors, high-grade tumors, and ER-negative tumors. And so it seems that the more strongly expressed genetically of African ancestry, the more likely it is that you will have certain patterns of breast cancer. Since we've had 4 centuries of genetic admixture in the African American population in the United States since the slave trade, we tend to see all of these features expressed to an intermediate extent between white Americans, European Americans, and contemporary African populations. Africa is obviously the homeland population for all of mankind, however, and so whatever this feature is that's driving the risk genetically of triple-negative tumors is something that we will see around the globe. So we've gone on to look at other features that may be associated with these biologically more virulent triple-negative breast cancers, such as ALDH1, which is now coming to be commonly accepted as being a marker of the mammary stem cell, and the mammary stem cell being the subset of the tumor population that seems to drive risk for distant metastatic spread of breast cancer. In looking at extent of expression of this mammary stem cell marker ALDH1, we see very, very high expressions of it in Ghanaian breast cancer tissue. Again, intermediate expression in African Americans, notably lower expression in white Americans and in Europeans. We looked at the French population. And this expression was actually seen in another population from Africa in Uganda, where they found almost the exact same results that we found for Ghanaian women. And very interestingly, we also found high expression of this mammary stem cell marker in benign Ghanaian breast tissue. Another marker, EZH2, which also seems to be associated with risk of driving virulent tumors, also has unique expression in Ghanaian breast tissue. We've gone on to create essentially a library of patient-derived xenografts where we have extracted tumor tissue from triple-negative breast cancer patients that we are operating on in Ghana, and then through jumping through an incredible number of hoops, we've been able to get the breast tissue, while it's still viable, to the United States for implantation in immunosuppressed mice and create these patient-derived xenografts, which gives you a very exciting research opportunity, because now you have several generations of these mice and these tumor xenografts in the mice mammary fat pads, so that it's a renewable supply of these tumors, serving as a source for studying their tumor biology and hopefully for being able to test novel treatments against these triple-negative tumors. Now, many of you have probably already come to appreciate this very exciting literature looking at triple-negative breast cancer subtyping. It has become apparent to us that triple-negative breast cancers do not represent one single disease. There are very likely different subsets of triple-negative breast cancer where the tumors grow through relying on different pathways. The Vanderbilt University group was one of the pioneers in figuring out this concept of triple-negative breast cancer subtyping, and they defined these subtypes, which seem to be 6, possibly 7 different categories, by looking at publicly available gene expression profiles. The gene expression profiles that they looked at all came from populations that were of predominantly African descent. They mainly came from the UK, Sweden, some from the United States, where you would assume there was probably a minority of the participants were African American, the Netherlands, even some from Asia, but none from Africa, and again, very few African Americans being represented in this work. Now, this work is very powerful because these triple-negative subtypes seem to be associated with likelihood of responding to the standard chemotherapy that we use as systemic therapy against triple-negative breast cancers. And the triple-negative subtype may also predict for ability to respond to novel systemic therapy agents, such as anti-androgen agents in the form of bicalutamide. So it is very important for us to learn more about these triple-negative subtypes. However, we really don't know if the triple-negative breast cancers that we see so highly prevalent in African Americans and Africans represent the same subtypes that we see on a less frequent basis in white Americans and Europeans. So we've tried to at least start to tease out the answer to this question by looking at immunohistochemical surrogates for some of these triple-negative subtypes. And I'm going to jump to the summary slide here in this work, where we have looked at not only ALDH1 expression, but also androgen receptor expression, because you would expect, based upon the work that's been done in triple-negative breast cancer subtyping, that these two markers might represent different pathways for the different triple-negative breast cancer subtypes. What we found was that there does seem to be an interesting subset of the triple-negative breast cancers that we see in Ghana that has co-expression of both ALDH1 and androgen receptor, suggesting, I know this is a leap of faith, this is certainly not true gene expression profiling, but it's a step in the direction of trying to figure out something about the patterns of triple-negative disease in Ghanaian women. And these data suggest that there might be a triple-negative breast cancer subtype that is unique and as yet undefined, but which is more highly prevalent in women with African ancestry. And I am very happy to say that we have been recently funded by Susan G. Komen to actually conduct a study of gene expression profiling of these triple-negative breast cancers, so that we can define triple-negative subtypes in white American and African American women based upon our very strong Henry Ford Health System patient population compared to the triple-negative breast cancers that we see in Africa. So again, I'm very, very excited about partnering with you and seeing that work move forward. So our ultimate goal in all of this work is to eliminate the threat of breast cancer worldwide, but through these international collaborations, we get such a gratifying experience for so many on so many different levels. And so the next few slides, I just want to show you some of the heartbreak of breast cancer in Ghana, where unfortunately we do continue to see these really horrific cases of women that have had cancers gone untreated for many, many years. And this certainly explains for some of the high mortality rates that we see in Ghana. Through investing in this international research program, we have, however, had very exciting opportunities to also invest in the overall health care of Ghana by working with the hospitals where we have been conducting this partnership. The facility where we work, however, is still horribly, horribly under-resourced. So the next few slides represent the Comfort Teaching Hospital Surgical Suite, and you can see it is nothing like what we have become so accustomed to in the United States in terms of surgical resources. The women usually don't even have sheets on their stretchers right outside the operating room. If you have the luxury of having medical records at all, they're usually compiled in a cardboard box, as is the case here. Similarly, in the recovery room, very few sheets on the stretchers. This is our sterile scrub sink. And if you are operating late in the day and the running water runs out, what happens is that you scrub with a bar of soap and the nurses pour water from this trash can onto your hands to rinse you off before you go into the operating room to perform surgery. So through the investment in the Comfort Teaching Hospital facility, because of this international research program, we again have had some marvelous opportunities to see improvements in what they have available. So through this program, we have seen the establishment of a multidisciplinary breast oncology program at Comfort, and we partner and communicate with that program on a weekly basis, but through telemedicine and convening weekly conferences where we talk to each other about the breast cancer cases that are being seen and share information regarding treatment planning. So just some more photographs from that telemedicine program. A highlight of every visit is when we get to visit the pediatrics unit in the hospital. There's actually a school on the same floor as the pediatrics unit, so we always have a great time bringing educational materials, toys, and such to the kids in the pediatrics unit. In investing in the program, we've been able to supply financial support and educational training to the nurses, the physicians, the pathology docs, and again, it's resulted in the creation of a dedicated multidisciplinary breast oncology team in this facility. Prior to about 4 years ago, the group at Comfort did not have an immunohistochemistry program, so they didn't even know whether their patients had estrogen receptor positive or HER2/neu overexpressing cancers. Here we take this for granted as being a very basic bit of information that we use routinely in defining the management of each and every one of our breast cancer patients. They didn't even have that in Comfort and don't have it still in many of the hospitals in Ghana because of resources and training deficits. They didn't have core needle biopsy availability, and so any woman with a breast abnormality had to utilize very scarce surgical resources to have to undergo an operation to determine whether or not she had cancer. Through this research collaborative internationally, we have been able to establish an immunohistochemistry program at Comfort, and so now they do their testing on each of their patients routinely, and patients are evaluated by their multidisciplinary team in clinic and will routinely undergo core needle biopsies in order to establish a breast cancer diagnosis so that they can preserve their very precious surgical resources. And we've had the pleasure of being able to expand this system. And through the International Center for the Study of Breast Cancer Subtypes that you heard about that's been very recently created, we are thrilled to be able to support expansion of this program that has been ongoing for the past several years. We now not only work with the Comfort Teaching Hospital services, but we work with the Senyani Hospital in Ghana, the Tamale Teaching Hospital, and we have also been partnering with a hospital in Ethiopia representing East Africa, the St. Paul's Millennium Hospital. We have a facility in China and yet another hospital in India where we are looking forward to amassing specimens for analyses. And now I want to just take a couple of minutes to talk to you about our very recent findings with regard to looking at the breast cancer burden of West Africa versus East Africa. So we talked about some of these data previously in terms of the high frequency and very young age at breast cancer diagnosis for Ghanaian women. Ethiopia, we see similarly very young average age at breast cancer diagnosis, high frequency of high-grade tumors in African Americans, Ghanaians, and Ethiopians. When it came to the breast cancer phenotypes, however, we had a surprising finding. As expected, we continue to see the very highest frequencies of ER-negative and triple-negative cancers in the Ghanaian women, but we saw actually relatively low frequencies of ER-negative tumors and triple-negative tumors in the Ethiopian patients. And the frequencies of these tumors for the Ethiopian women was actually pretty similar to the frequencies of ER-negative and triple-negative tumors in white American women. And we saw an increased prevalence of HER2 overexpressing cancers in the Ethiopian women. Now, unfortunately, because of scarce tumor registry resources, we didn't have many clinical pathologic features that we could control for in these studies, but we did have age at diagnosis. So we did go on to perform subset analysis for the frequencies of these phenotypes in women younger than the age of 50 at diagnosis, and the patterns persisted. Highest frequencies of the triple-negative tumors in the Ghanaian women, lowest in white Americans, intermediate for African Americans, notably low frequencies of triple negatives in the Ethiopian women. And in comparing just couplets, what we saw was that the Ethiopians were most similar to the white Americans. Now, if you try to figure out why these patterns might be the case, it actually makes sense when you look at slave trade patterns from several hundred years ago. The transatlantic slave trade largely brought Africans from Western Sub-Saharan Africa, including Ghana, over to the United States, and so we very definitely have shared ancestry between African Americans and Ghanaian populations. The Ethiopian slave trade was largely controlled by Arabic populations, and that slave trade largely went in the opposite direction, and the Ethiopian slaves were more commonly sent over to the Asian countries. And so African Americans do not have quite as much shared ancestry with Ethiopians as we have with Ghanaians. And so that may actually explain why we see these different prevalence of certain tumors in the different patient populations. So we've tried to figure out whether or not these limited patient populations that we've been evaluating are representative of larger populations. The African American and white American populations from the Henry Ford Health System are very, very representative of what we see in national data looking at the surveillance epidemiology and end results program. Ghanaians, similarly, that we've been looking at Comfort, seem to have similar patterns when it comes to breast cancer burden in looking at other studies of the breast cancer burden of women from Ghana. There is very little in the published literature to define the breast cancer burden of Ethiopia, so we didn't have much to compare our findings to. But there is a group from Germany that has looked at the frequency of estrogen receptor negative breast cancer in Ethiopia, and they have found that the frequency of estrogen receptor negative tumors is much more similar to what we found in Ethiopia compared to what you see in African Americans and in the Ghanaian breast cancer patients. So our study is still limited by the fact that we don't have a lot of clinical pathologic information to add into these comparisons, but we are very, very excited about the hypothesis generating aspects of this work, and we are very excited about expansion of our efforts so that we can look at larger patient populations and so that we can go on to perform genotyping that will actually allow us to quantify extent and type of African ancestry. And this genotyping technology is right here and readily available in the form of ancestry informative markers that we can look at when we obtain germline genetic studies based upon either saliva samples or blood samples. So I thank everybody for their time and attention, and I also thank you for welcoming me to the Henry Ford family.